Okay, in this next series of videos, we'll look at pituitary gland pathology, some very important disorders that we need to be familiar with. First, I'm going to talk a bit about how we assess pituitary gland function, both through laboratory testing and imaging. And then I'll do a general introduction on both hypo and hyper pituitary states. And we'll talk about specific causes of low pituitary adenomas, which cause usually high pituitary secretion, and some specific types of adenomas like prolactinomas, growth hormone secreting adenomas, and then ACTH adenomas. And then in the following video, we'll look at posterior pituitary disorders, specifically SIADH and diabetes insipidus. So how do we assess pituitary disorders? Well, of course, our history will be one place. So any history of endocrine dysregulation we're going to want to consider is the pituitary playing a part here. And I'll give you examples here as we go. But with pituitary tumors in particular, adenomas are the most common. We might see things like a frontal headache. In very larger tumors, more than a centimeter, we might see problems with the visual fields. We'll lose vision in the lateral half of the visual field on both sides, and that is known as bitemporal hemianopsia. So that's where we can do our visual field testing and see if there's any changes there. That's going to be pretty rare with small adenomas, and those are going to be the ones that we're going to catch usually early on. This will be for more larger tumors. In, again, large tumors, we might see problems with increased intracranial pressure. And so cerebral spinal fluid pressure goes up, and that can lead to headaches, very severe cases, nausea, vomiting, papilledema, those kinds of findings. So that would be our history and physical exam. Now, laboratory testing is going to be one of our major ways we assess, and that would be through assessment of specific pituitary hormones and maybe their downstream target hormones. So we're going to have different protocols depending on what our conditions are. But basically, with growth hormone, we usually don't measure growth hormone directly. We're going to measure IGF-1 typically. It's a better measure of growth hormone activity. ACTH can be measured, TSH, very commonly measured. FSH, again, we commonly measure those. Prolactin. Oxytocin, we rarely measure that. I've never done an oxytocin test before, and really I don't know of many labs doing that. I'm sure it's available. ADH also can be tested, although the problem with ADH is it can take several weeks to get the results. It's not a very fast turnaround time on this test. So we'll talk about indirect methods to assess ADH. We might check, though, with thyroid. We might want to do downstream thyroid hormone testing. So T4 and maybe T3. I'll get into when we actually need to measure T3. It's not as common as you would think. FSH and LH, we're going to measure estradiol and testosterone potentially. And then with ACTH, we might measure cortisol downstream as well. So this would be one of the ways we assess pituitary. We might also test specific responses of the glands. So there are very specific things like the rapid ACTH stimulation test, also known as the cosentropin test, where ACTH is injected intravenously or IM. And then we measure cortisol at 30-minute intervals over a period of time after that to see how well your HPA axis responds. These are more specialized tests. I don't know of a lot of naturopaths doing them, but there are indications for this, like working up Cushing's or working up Addison's, that we'll need to be familiar with. Usually we refer out for these tests to endocrinologists if necessary. Imaging tests, the most common is going to be MRI. You can use CT, but MRI, usually with contrast agent, a gadolinium contrast, gives you the best resolution. So if we're concerned about pituitary tumors, in this case, we can actually see in this MRI a couple of tumors, all indicated with the green arrows here. These are little hyperfocal areas. With contrast, MRI can visualize down to about 2 millimeter tumor sizes. And so those are known as microadenomas, and they're usually very treatable at that early stage. So MRI, probably the best contrast agent. And usually this is referred to as not just a pituitary MRI, but a whole brain MRI. But on your, requisition forms, if you send patients out for this, just indicate that it's for the pituitary and that's what you're specifically looking for. The main contrast, again, is gadolinium, and there you have to be careful that a person has adequate renal function. So if you fill out the requisition forms for pituitary MRI, and if you request contrast agent, you need to have kidney function tests to go along with that as well. Now, importantly, about 10 to 20% of the general population has pituitary adenomas, microadenomas, but they are non-functional, they're not symptomatic, they're not growing, and we call them incidentalomas. So lots of pituitary incidentalomas, and we need to know when it's important to work those up, how do we monitor those, and so forth. So I'll get into that here shortly. Okay, let me just do a quick introduction of pituitary disorders here. So first of all, diseases of the anterior pituitary are a lot more common, and they produce a lot more symptoms than of the posterior pituitary. And for oxytocin, we usually don't talk about that, so we can take that one off the list. So that simplifies things a little bit. Usually we think of pituitary disorders either as a hyperfunctioning problem, where you oversecrete one or more of the relevant hormones, or a hypofunction problem, we undersecrete the hormones. And so those would be the most common disorders. Very rarely you can have genetic problems of the receptors for the different hormones. And that's not typical clinically, but that's something to just keep in mind, especially if patients exhibit signs and symptoms of pituitary hormone deficiency, but their levels are low or even elevated. It might be a downstream receptor problem that we need to think about. The most common pituitary disorders are going to be pituitary adenomas, and the most common of those will be prolactinomas that secrete elevated prolactin. Diabetes insipidus, and when we say central, that means that we have low from the brain and pituitary, low output of ADH. There is what's called nephrogenic diabetes insipidus we'll look at, and that's when the receptors for ADH in the kidneys become desensitized to ADH. And that can happen from a result of like taking too much lithium as medication or something like that. There's syndrome of inappropriate antidiuretic hormone, ADH. We talked about that. And then probably the least common on this list would be in children. Tumors of the hypothalamus called craniopharyngiomas can result in usually low secretion of these different hormones. So if we look at pituitary hypopituitarism, this is a lot less common than hyperpituitarism, so low secretion is less common than the elevated secretions. And it can be result from a deficiency of a single hormone, but typically we get what's called pan-hypopituitarism. And that can be the entire gland stops secreting all of its hormones, and we're going to have then downstream problems with cortisol, with thyroid, with sex hormones, and so forth. If the growth hormone is depressed from the anterior pituitary, that can lead to pituitary dwarfism. If in the posterior pituitary we have low ADH, that can lead to diabetes insipidus. Again, all the other hormones can lead to deficiencies of theirs as well. These are probably the two most common on this list here. That said, pituitary dwarfism is not that common, so that's one we pretty rarely see in the clinic. Causes of this would be a pituitary adenoma, a very large one. So large adenomas tend to get necrotic in the middle, and then we get a collapse of the tumor, and you stop secreting those cells. I'll just say here, adenomas usually develop from a single type of cell, one of the 5 cell types in the anterior pituitary overgrowing. These are not metastatic tumors, they're just overgrowth of those cells, but they can locally infiltrate, and they can actually invade the sphenoid bone, they can compress the stalk, the infundibulum, and so forth. And so they can have all sorts of problems as they get bigger. And we usually use the arbitrary cutoff of 1 centimeter as the big indicator. So tumors under 1 centimeter are known as microadenomas. Tumors over 1 centimeter are known as macroadenomas. And the microadenomas have a lot better prognosis. They have a lot less sort of symptoms and signs, versus the macroadenomas usually have a lot more invasiveness and a lot more problems associated with them. Craniopharyngioma can lead to hypopituitarism. Pituitary apoplexy, we'll look at all of these in detail, but apoplexy is essentially a stroke, a collapse of the circulatory supply to the pituitary. And that can happen with larger tumors that infarct. Sheehan Syndrome, which happens after pregnancy, so after delivery, I'm sorry, where you might have a massive hemorrhage, massive blood loss, and that actually causes a pituitary ischemia, and that can result in a decrease of all the different hormones, either temporarily or actually can go on for years. Empty sella, that's where the pituitary actually gets compressed and shrinks in size. And then trauma or infiltrative disease like hemochromatosis and sarcoidosis can destroy the pituitary. So all those would cause hypopituitarism. Hyperpituitarism is more common, and usually this is an excess secretion of usually just one pituitary hormone. So if you get increased growth hormone, that can lead again to the gigantism or acromegaly. Increased ACTH would be Cushing's disease, and then increased prolactin, hyperprolactinemia. Posterior pituitary would be increased ADH, that would be SIADH. Notice I didn't put TSH or the gonadotropins, and that's because adenomas with those are very rare. It can happen though, so got to keep that on your list. Usually the adenomas are the most common cause. Again, ADH can be oversecreted after trauma, surgery, kidney disease, and so forth. We'll get into those causes. So those are the kind of biomedical conditions to know about. Now, a lot of the conditions we see in the clinic around stress and inflammation and general chronic disease in the body involve a dysregulation of one or more of the pituitary axes. The most common one is going to be the HPA axis. We can also have dysregulation of the HPT axis, that's thyroid metabolism, the HPG axis, which would be your gonads, and that can lead to menstrual irregularities and problems, and then even growth hormone dysregulation. So these are things we tend to think about more from the naturopathic angle. So stress is a major cause of this. And I mentioned in the very introductory videos the endocrinologist Hans Selye, who developed this general adaptation syndrome, which we'll go into in more detail later. But the GAS describes the stages of the stress response. Usually first there's overactivation of the sympathetics, followed by overactivation of the HPA axis, followed by exhaustion of the HPA axis. And so we can target the different stages of the GIS if we understand that with different supportive therapies. Inflammation can also cause a pituitary axis dysregulation, and that would be elevated pro-inflammatory cytokines. Sleep disturbances, we talked about that with growth hormone. Nutritional deficiencies of either macro, but more specifically micronutrients, trace elements, cofactors, and so forth. And then insulin resistance. All of these can either up or down regulate pituitary axes. Again, HPA axis is probably our classic one here, where cortisol secretion feeds back and should turn down CRH and ACTH secretion. But with chronic stress, we downregulate those receptors in the brain for cortisol. So the HPA axis starts to go wonky. So we start to see things where our cortisol levels start to fluctuate throughout the day. We might get surges of cortisol at the wrong time, and then over time we start to go into more of an exhaustion phase. This is describing the 3 phases of the general adaptation syndrome. But this is where we can intervene. I do this often with herbal therapies, but also with lifestyle level 1 therapies on the therapeutic order to really balance this out. There's various assessment methods. Some of them are more controversial than others. We typically, in the conventional endocrinology world, use plasma hormone assessment, like I just talked about with the pituitary hormones in the last slide. But a lot of, to look at functional disorders, we need multiple time points throughout a day. And that's where salivary testing, which also measures the free hormone levels better than total hormone levels in the blood, is more accurate for that. The problem with salivary testing is it's not universal. There are labs that have really specialized in this, like ZRT Lab and so forth, that have all the equipment and the training and expertise to run it. Other labs around the country are not as prepared for that, so that's why in the conventional endocrinology circles, they don't really look at this as a valuable testing method. But in the research literature looking at adrenals and HPA axis and whatnot, this is the preferred method for assessing adrenal function because it's non-invasive. You can get it at multiple time points, including midnight and so forth, very easily. And we are measuring the free hormones. There's other ways. Urine also is another way, especially looking at hormone metabolites in the urine. So these are our three primary methods we can use to assess more functional dysregulation of the axes. There are other ways. For example, there's something known as endobiogeny. I'll just mention that here. It's a system of medicine developed by endocrinologists in Europe, France primarily, that's now taught in the States. Naturopaths are part of the training programs now. It's also known as the biology of functions. And what they look at is not so much hormone levels, but how, when we look at hormones in the body, like what effects do they have on other tissues? And they use standard lab tests like a CBC, CMP, and they do different ratios, looking at, for example, the amount of neutrophils to lymphocytes and these different things as an indirect measure of adrenal function or estrogen activity and so forth. So I'm not going to talk too much about this, although if you want to do training in this, I think there's a lot of opportunities now. There's a fellowship training that's available, I think in Chicago. And they really go into this. They have published some of their information, but a lot of it is still kind of kept within their circles. Hopefully with time, more of that information will get out and we can start to integrate more of these functions into endocrine assessment. So that's another way of assessing more functional endocrine problems. The treatment of functional endocrine problems really is where I think we have to be careful, because historically naturopaths sometimes for like adrenal dysregulation would actually give cortisol in these different things, and the conventional endocrinologists really were kind of shocked by that because we can run the risk of over-medicating patients, especially with high cortisol and so forth. So really we want to focus on, for the functional disorders, targeting level 1 and 2 of the therapeutic order. And this would be level 1, again, diet, exercise, lifestyle like sleep, hygiene, and stress reduction. And level 2 would be our basic nutrition, specific nutrition, micronutrients, herbal medicine, low-dose homeopathy under Avogadro's number, as I discussed previously, acumoxotherapy, and so forth. So this would be where we really do a lot of this clinically to address these axes. So I just wanted to point this out because this often gets missed in the conventional descriptions of the pituitary and the conventional endocrinology textbooks. So let's look first at hypopituitarism. Again, this is a lot less common than the hyperpituitarism. This will be an underactive pituitary gland. And we're going to focus it primarily on the anterior pituitary, although you can have it, of course, with the posterior. So this would be diminished or absent secretion of one or more pituitary hormones. Again, more rare. You have to have a destruction of about 75% of the anterior pituitary to actually manifest symptoms of a hormone deficit. And usually we only have one or two hormones that are deficient, and then their target organs will begin to atrophy. But you can have what's called pan-hypopituitarism, where the entire gland stops secreting. Primary hypopituitarism would be caused by destruction of the pituitary, and secondary would be due to deficiency of the hypothalamic stimulating the tropic hormones. So that'd be more of a hypothalamic problem, a lot less common than the primary. And then again, in general, these are very rare. The clinical presentation will vary depending on what hormones are deficient. So we're going to maybe in the history see, we suspect hypothyroidism, but we also are seeing low estrogen and maybe even low adrenal function. And we're going to start doing some measurements, and that might lead us back to the pituitary being the primary source of all this. So the presentation we can divide into acute or chronic. Acutely, the loss of ACTH is probably the most emergent one, and that can lead to adrenal insufficiency and lead into what's called adrenal crisis, and that can be fatal. So that's the one that's really a medical emergency, that's a red flag, and that would be from low ACTH. And I'll talk about the causes down below and when we need to think about that. The other acute one would be actually high ADH, and that would be SIADH and hyponatremia. So what can happen is we can get hypopituitarism from the anterior pituitary, and that can dramatically upregulate the ADH, so we kind of get opposite effects. More chronically, though, we're going to see things like low prolactin, which would lead to, let's say, after pregnancy, agalactorrhea postpartum, low TSH with hypothyroidism, low gonadotropins, and that could disrupt menses, infertility, have low estrogen and testosterone. And that can play a problem if this happens, for example, with premature, before the age of 40. In females, that low estrogen can lead to severe osteoporosis, and so that needs to be corrected, usually with replacement therapy. And then low growth hormone might lead in adults to low, fatigue, decreased muscle mass, and bone density, versus, of course, in a child that might lead to pituitary dwarfism. Now, what are the causes of all this? Well, probably the most common would be pituitary tumors, pituitary macroadenomas, the larger pituitary tumors, which would cause the gland eventually to stop functioning. Curiously, the microadenomas tend to be hypersecreting. So you can have adenomas do both. And then the hypothalamic tumors, the craniopharyngiomas, will cause a disruption of the hypothalamic tropic hormones. And we'll talk about these in depth, so I don't want to talk about them here. Pituitary apoplexy would be bleeding into or an impaired blood supply of the pituitary gland, and that can happen with a tumor that can sort of go necrotic in the center of the tumor, and then it collapses the circulatory supply in the tumor. It can also be idiopathic. We just don't know what causes it. This one can be a medical emergency because of the potential for adrenal crisis. So patients might present with a severe headache, they start getting visual field defects. So the idea would be they had a tumor growing here for maybe years or decades, it got big enough, they ignored it, and now it undergoes this infarction. And now we get a severe loss of ACTH, and that can lead to adrenal crisis. So that's where we need to quickly evaluate that and refer on for the appropriate care. Not common, but good to know in the back of your mind. Sheehan syndrome is probably something we'll encounter more commonly in the clinic, and this is postpartum pituitary gland necrosis. So during pregnancy, you need a lot of hormones to maintain the fetus in the mother, and the pituitary gland actually grows, but the blood supply to the pituitary doesn't really grow. And so the pituitary during pregnancy is sort of on the border of ischemia the whole time. Now, if at delivery you have a massive hemorrhage with the delivery, you lose a lot of blood volume, that can actually result in a dramatic disruption of blood supply to the pituitary. Pituitary goes ischemic, could potentially infarct, but the cells usually stop secreting their relevant hormones. And that can be a temporary thing. It could reset pretty quickly after, after delivery. Or it can go on for years, and a lot of women actually have very low symptoms of low thyroid and whatnot. They don't really get that investigated until years later, and then we're able to trace back, it actually started after delivery. So that's Sheehan syndrome. And again, you can have various degrees of presentation. A lot are asymptomatic, have mild symptoms, again, might not be diagnosed for years later. Can also have massive pituitary collapse, could have the adrenal crisis. That would be pretty rare, but that's certainly something to be aware of. And then many women actually just have low prolactin is the first sign that triggers us to investigate this. They don't make breast milk, they have agalactorrhea, and it's a result of the low prolactin. So that's Sheehan syndrome. Another cause of hypopituitarism would be empty sella syndrome. And that's where the pituitary gland shrinks or becomes flattened. And the sella turcica, that space in the sphenoid bone, becomes filled with cerebrospinal fluid. And the causes of this can be what we call primary, and that's usually from a congenital problem of the development of the pituitary. It can also occur because of increased intracranial pressure and hypertension. Intracranial hypertension, and this happens more commonly in females that have higher BMI, and so with hypertension in general. And then secondary causes would be tumors, surgery, or radiation. So that's empty sella syndrome. Usually the primary is pretty mild. It can be asymptomatic or just mild hormone deficiency. But secondary can have varying degrees of headaches, visual field defects. So as the cerebral spinal fluid fills the space, it actually starts to compress more on the pituitary and the stalk. It can actually compress into the optic nerve. And then it can result in various degrees of hypopituitarism. So that's one to think about. And this is usually assessed doing a pituitary MRI. And you actually see on the MRI that the sella is empty. Its pituitary is shriveled to a little point, and the sella is mostly filled with cerebral spinal fluid. Other causes of hypopituitarism: brain injury, radiation surgery. Again, we might see different varying degrees of hypopituitarism from that. Infiltrative disease like sarcoidosis, hemochromatosis, Langerhans, histiocytosis, lymphocytic infiltration or infections like in TB could also cause hypopituitarism. And then a specific low secretion would be growth hormone. And again, this is going to be most noticeable in children. And that can be congenital or acquired. And in children, we're going to see varying degrees of pituitary dwarfism. And that's going to be a short stature with normal proportions, though. Now, it's very important with short stature. The majority of these cases are not from pituitary problems. They are from achondroplasias. So achondroplasia is a problem of the bone, genetic problem of the bone development. And usually they develop what's called disproportionate dwarfism or short stature, and that's because the bones develop at different rates and so forth. So be careful to differentiate that. Pituitary dwarfism is a lot less common than the achondroplasias. The presentation of growth hormone deficiency is going to vary. Depending on if it's just an isolated growth hormone deficiency, that's about a third of cases, or if it results from pan-hypopituitarism, that would be 2/3 of cases. There you'd have to think about replacement of, again, the downstream hormones like cortisol, thyroid, and then the sex hormones if it's appropriate. So that would be a more specific example of hypopituitarism. All right, so that's a general summary of all the different conditions and the different manifestations of low pituitary function. I want to say a few more things about hypopituitarism here. So our assessment is going to be kind of what I talked about in the first slide on this series, and that is to do a complete history physical exam. For like low growth hormone, we might check our body proportions and growth curves. Visual field testing might be important for detecting larger pituitary tumors. But then our blood tests, we might just check generally our CBC, CMP, coagulation studies, but then we're going to go and test all of the individual pituitary hormones, including ACTH and cortisol, prolactin levels, TSH, and usually free T4 only is needed, and then growth hormone, but specifically IGF-1, the gonadotropins, and then in females, we're going to check estradiol, and males often testosterone. So this would be, especially for working up Sheehan Syndrome, for instance, we might need to go through all these different hormones. And then a brain pituitary MRI might be indicated as well. The therapeutic order is going to depend on the severity of the condition. Usually, again, for pituitary apoplexy, this is a medical emergency. We're going to need to do a direct referral to the emergency department, and they need to be stabilized with hydrocortisone, etc. Pan-hypopituitarism or more severe is going to need level 3 replacement therapy. And we're probably going to need to consider referral to endocrinology in general for these cases, because they're going to be potentially difficult to manage by yourself in a primary care setting. So generally with replacement therapy, we're going to look at if it's an adrenal crisis, in the ED, what they're going to do is IV saline and hydrocortisone. And often they'll need to also do fludrocortisone. Usually, though, if it's a pituitary cause of the adrenal cortical insufficiency, again, that's called secondary adrenal cortical insufficiency, they will still secrete mineralocorticoids like aldosterone. So they won't need necessarily mineralocorticoid replacement, but they will need cortisol replacement. Chronically, though, we might need to give thyroid hormones, sex hormones, and then growth hormone is going to be primarily reserved for children with growth hormone deficiency, and that's going to be by injection. But again, there's risk factors that could be cardiac hypertrophy, hyperglycemia, diabetes, and then edema and joint pain. So that's going to be level 3 therapies. Level 4 therapies would address tumors, and I'll talk about that with pituitary adenomas coming up. We can also think level 2 would be, supporting salutogenesis, and that's going to vary by the condition, but we might think of adaptogens. Stimulating adaptogens, again, are those that increase the HPA axis, maybe increase the cortisol awakening response, like Panax ginseng, rhodiola, schizandra, Codonopsis, licorice. Those would be some examples of stimulating adaptogens. That's in opposition to the sedative adaptogens like ashwagandha, bacopa, holy basil, magnolia. Those would be some examples of sedative adaptogens. So here, more stimulating. Phytoestrogens, we'll talk about those in depth in the estrogenic section, in the female reproductive section. But that would be things like black cohosh, potentially, but also rhamania, trifolium, the red clover, medicago, and so forth. I think Dr. Wieman might go through some of those as well. And then phytoandrogens would all upregulate androgen activity. Again, if we don't have the tropic hormone stimulating, those glands, giving the herbs alone would probably not be enough. These herbs are better at regulating the HPA and the HPG axes versus just directly stimulating them. Micronutrients might also be important here as well. No current guidelines yet for diet, exercise, lifestyle, stress reduction, but here we're going to need to take their estrogen status, testosterone status into consideration, and you'll learn more about that as we discuss those in more detail. Okay, so that's an overview of the assessment and treatment of hypopituitarism. So next I'm going to talk about pituitary adenomas. They primarily cause hyperpituitarism. And they account for about 10% of all intracranial neoplasms. The peak incidence is between 30 and 60, and a lot of them remain undiagnosed, and we think there's a general prevalence of about 17% in the population. Most are isolated, solitary lesions without any associated other neoplasms, and they can produce symptoms either by hypersecreting the individual hormone that the cells are derived from, or they can compress the stalk of the infundibulum, and I'll talk about that. That's called the stalk effect. Or they can have local effects called the mass effect, for example, compression of the optic nerves causing the bitemporal hemianopsia, etc. About 10% are asymptomatic and non-functional. Again, we call these incidentalomas. We usually, if we find these on incidental imaging, maybe for something else, they did an MRI of the brain for some other reason, we would then just go through a complete history exam, maybe do some lab tests to see if they're actually hyper or hyposecreting. About 3% are associated with what's called multiple endocrine neoplasia type 1. This is a genetic problem where you have different problems of different endocrine glands, and the pituitary adenomas is one possibility. Usually the adenomas are composed of a single cell type that secretes a single hormone. So there's an adenoma of lactotropes or corticotropes or thyrotropes, and they will secrete their respective hormones. Again, microadenomas are less than 1 centimeter in diameter. They are the most common, and they're going to cause hyperpituitarism generally. Most remain undiagnosed. They may or may not be secreting, and they're usually easier to treat, and they have fewer of the mass effects and the stalk effects than the macroadenomas, which are more than 1 centimeter in diameter, and they're more difficult to treat, and they often over time cause hypopituitarism. Usually we divide the adenomas into whether or not they're benign. That's the most common. And then if they're benign, are they secreting or non-secreting, that we can assess via the lab tests. Are they invasive? That's about 35% of them. And then very, very rarely you can get a carcinoma. And so that can be a direct carcinoma of the pituitary, but also other cancers like small cell of the lung and breast, small cell lung cancer and breast cancer can metastasize to the pituitary. This is going to be more common in the elderly, and that can actually cause a carcinoma. That would be more of a secondary tumor in the pituitary. So those are the 3 different types of adenomas. We also classify them by their size. So stage 1 would be microadenomas without any cellular expansion. Stage 2 would be macroadenomas that may extend above the cella. Stage 3 would be macroadenomas that invade the floor of the cella, invade the floor of the sphenoid bone, as well as supracellular extension. And stage 4 would be destruction itself of the cella. So you might see that on anatomical reports if you have patients with adenomas. And then we can also classify them finally functionally based on the hormones secreted. So prolactinomas are the most common. It's about 60%. Growth hormone adenomas are about 20%, and then ACTH adenomas comprise 10%. And as I mentioned before, TSH and gonadotropin hypersecretion is very rare, but something to be on the lookout for. If you have, for example, a patient with hyperthyroidism, they test negative they have elevated TSH with hyperthyroidism. That's not going to be the case in Graves, where you're going to see elevated thyroid hormones with low TSH. You're going to have positive antibodies. If you have negative antibodies, high TSH, high thyroid hormone, you might consider a hypersecreting TSH adenoma. The effects of the masses are going to be either one of two. One is called the mass effect, and that's going to be a direct pressure exerted on nearby tissue. So if you look at the sphenoid sinus here, let me put that in red. If you look at the sphenoid, here's the pituitary, here's the optic chiasm, here's the hypothalamus up here, here's the sphenoid sinus, here's the cella sitting in here. Notice that we, of course, have the cavernous sinus on either side here with a lot of cranial nerves going through here, which affect vision. So very large tumors can actually compress in on that. But basically what happens is we can actually get the tumor exerting pressure up on the optic nerve, and that's going to cause the visual field defects. It can also increase intracranial pressure on the third ventricle up here, block the outflow from the third ventricle, so that's going to increase intracranial pressure, and that can create headaches, papilledema, nausea, vomiting, and so forth. But it can also compress the stalk, and that's called the stalk effect. And what happens there, paradoxically, is we actually get an increase of prolactin from the anterior pituitary because we block the dopamine from the arcuate nucleus and the hypothalamus from coming down. So basically, that results in high prolactin, and then we're going to get low ADH because we're compressing the neurons coming down from the from the hypothalamus to the posterior pituitary, and that can result in diabetes insipidus. So high prolactin. Diabetes insipidus would be results of the stalk effect. So these are some of the characteristics of pituitary adenomas. So how do we assess adenomas if we suspect one? Well, first is going to be, again, from history and physical exam. So you might see, for example, nipple discharge bilaterally with high prolactin. Unilateral nipple discharge can be more related to breast pathology, not so much high prolactin. Increased growth hormone, acromegaly in adults, gigantism in children. Increased ACTH, and that would be Cushing's disease. Again, visual field defects like the bitemporal hemianopsia, increased intracranial pressure with headaches, and that can be described as migraine-like, frontal or stabbing headaches, etc. And then even psychiatric symptoms like depression, anxiety, but also a lot of emotional lability, instability, anger, aggressiveness that sort of comes out of nowhere. That might be something to think about, is a pituitary adenoma. And we're going to then measure the relevant hormones again, prolactin, IGF-1, the gonadotropins and sex hormones, TSH and thyroid, and ACTH cortisol. Just mention again on cortisol, we need to measure this at 8 a.m. Same with testosterone, if you're going to measure that, that's usually 8 a.m. Estrogen, we don't usually measure any particular time of day, and these others also we don't need to measure. So I usually, if I'm going to be ordering these, just schedule a patient to come in at 8 a.m., get all of them at the same time. And then a brain MRI, and if indicated, the gadolinium contrast. So treatment here generally needs level 4. So level 1, level 2 we can certainly do, and we'll talk about some options here. So I'll just very quickly mention that, if we have a prolactinoma, and I'll talk about that in depth in the next slide, in a prolactinoma, we can use things that increase dopamine like Vitex, and mucuna, the velvet bean, which contains L-dopa. We can also give cofactors or things to increase dopamine synthesis, like the different B vitamins, tyrosine, and so forth. And that can all increase the secretion of dopamine, and that will suppress prolactin secretion. So I've actually used that for microadenomas that secrete prolactin. That actually I have used successfully in several patients to just use that therapy. But generally, we're going to need to use a deeper pharmacologic therapy in these cases. So what are the common therapies that are used pharmacologically? Well, for prolactinomas, we can use dopamine agonists, and we'll go over those in just a second here. And then somatostatin analogs for the growth hormone adenomas. For the ACTH secreting adenomas, there really are no direct therapies to suppress ACTH, but we can work downstream to suppress cortisol. So those would be some of the pharmacologic measures. Surgically, this is kind of the mainstay of treatment for pituitary tumors that don't respond to pharmacotherapy. The primary treatment, especially for microadenomas, would be the transsphenoidal hypophysectomy, and that's essentially where going into the nasal passage, they drill out the sphenoid bone, and that gives direct access to the pituitary. And with very fine instruments that can go in, the neurosurgeon can go in and actually remove the different parts of the pituitary, the adenoma, etc. And that can at least help decompress the gland, especially if there's a mass effect or a stalk effect occurring. So this is a treatment of choice. It's about 90% successful for microadenomas. There are major complications in less than 5% of patients, and one of the biggest ones is SIADH that occurs within a week or two after the surgery. Usually that's temporary and that resolves with time. So that would be for the microadenomas. For more larger tumors that have a lot more invasion of the local structures, there's a technique known as the transfrontal craniotomy. They actually remove the entire frontal bone and they go in this way to remove the tumor. They have to peel up the frontal lobe and go in that way. As you can imagine, this has a lot more complications, a lot less of a success rate. So the real treatment of choice, and especially now with better technology, is to do the transsphenoidal approach. OHSU has actually a pituitary surgery center where they really focus on this, and that's if you make a referral for these kinds of surgeries, usually we're going to refer to endocrinology first, and then they're going to refer for the surgery. But if you do make a referral, you want to refer to a high volume center where they're doing a lot of this. They have special training in how to do this. There are radiation techniques as well, both conventional and then something called the gamma knife using cobalt-60. That can be used to at least reduce the size of the larger tumors. So that would be some of the pharmacologic treatments. Now, if the surgery results in, or the growth of the tumor results in a destruction of the pituitary hormones, then we might need to do hormone replacement downstream as well. So that would be the approach generally for pituitary adenomas. We currently don't have any specific dietary, exercise, lifestyle, or stress reduction guidelines, but these are always important to look at for just general health. Because they're so common, I want to really spend a little more time on prolactinomas. These are about 60% of the pituitary adenomas. They're going to oversecrete prolactin, and the high prolactin is going to interfere with the HPG axis. Typical prolactin levels are between 100 and 300 nanograms per milliliter, in a small secreting prolactinoma, but they can actually go up over 1,000 nanograms per milliliter. Growth of prolactinomas is usually very slow, which is a good thing because there's time to try different therapies. Most patients have microadenomas, especially females, and unfortunately in males, usually the symptoms are not noticed as early, and so the tumor grows into a macroadenoma, so they have more mass and potentially stalk effects. The presentation in females would be galactorrhea, amenorrhea or oligomenorrhea with anovulation, infertility, decreased libido, and then low estrogen, which might result in menopausal symptoms and osteoporosis if it occurs early enough in life. Usually under the age of 40 is when we're really concerned about the low estrogen for osteoporosis. In males, the main symptoms are decreased libido and impotence. Now, there's a lot of different causes, so we have to differentiate, the prolactinomas, they are caused a lot of times idiopathically, but there are a lot of things that can increase prolactin secretion in general, and that would be things like, high estrogen states like pregnancy, oral contraceptives, but also hypothalamic disorders, tumors, hypothyroidism. Remember, low thyroid states will increase prolactin. Again, your medications like SSRIs, SNRIs, antipsychotics, the neuroleptics, methyl-dopa. Liver disease, cirrhosis, because you tend to get high estrogen in those states, in a cirrhotic state. And then any sort of trauma, burn, injury to the chest wall, which is constantly activating those sensory nerves around the nipples, could increase prolactin secretion. So that would be some of the causes there. How do we assess this? Well, if you have a patient with bilateral galactorrhea and you suspect a prolactinoma, want to get a complete history. First of all, are they pregnant? That's the first thing you need to know. Is there a possibility there? What's their menstrual status, their fertility, their sexual function in general, like libido, and then are there any symptoms of hypothyroidism? Want to document all their current meds, including oral contraceptives, SSRIs, and so forth. Want to get a pregnancy test, basal levels of prolactin, LH, FSH, TSH, and free T4. I'll just say prolactinomas do also occur in males. The effects are going to be a lot less noticeable than in females, but again, low sexual function might be the first one there in a younger male. You're going to measure these same hormones, the prolactin, LH, FSH, TSH, free T4. In females, we're going to gather the serum estradiol, and males will do the testosterone, and then check liver and kidney function. And then a potential brain pituitary MRI could reveal the prolactinoma down to 2 millimeters if you use the gadolinium contrast. All right, so that's the general assessment for prolactinomas. Now, how are prolactinomas treated? Usually we're going to need, again, level 4 therapies here, and we might consider a referral to endocrinology. That said, a lot of primary care physicians for smaller adenomas are, capable of managing these cases. But for the larger tumors and ones that are not responsive to therapies, you're going to want to refer on. Most patients with microadenomas respond well to treatment, especially the dopamine agonists. Again, macroadenomas will have a poorer response. If your prolactin levels are high, but you do the imaging, you don't see anything on the imaging, the typical treatment is to watch and observe. I'm going to use level 1, level 2 therapies in that case. So things like the Vitex to increase dopamine. The typical standardized extracts have 0.5 to 0.6% agustides, and we do between 175 and 400 milligrams a day if you're using those extracts. I also use Vitex tincture, and sometimes I'll use between 10 and 30 drops. A lot of people might say that's a low dose, but I've had good success with that even at the low doses. Mucuna, I've never used this for prolactinomas. We tend to think of this for Parkinson's. That's a source of L-DOPA. And the sort of resources indicate we can take up to 5 grams a day of this. I don't have this in tincture form, and I don't have it readily available, so I don't typically use it in the clinic. Again, the more sedating adaptogens that tend to decrease the HPA axis, but I suspect they also can decrease the prolactin secretion, would be things like ashwagandha, bacopa, holy basil. Again, different than your more stimulating adaptogens like ginseng, rhodiola, schizandra, licorice. Phytoestrogens, Rehmannia, black cohosh, medicago, trifolium, again, might be something we use later to protect the estrogen in a female. Several micronutrients which would increase dopamine would be things like B6, the P5P, 1 to 500 milligrams BID, folate, the MTHFR, 1600, some sources up to 15,000 micrograms per day. I think that's pretty high. Tyrosine, 500 to 1500 milligrams a day. Again, that's the building block, the amino acid precursor to dopamine. Magnesium, and then GABA inhibits prolactin synthesis. So here I have also used, in conjunction to Vitex, Nervine herbs. Nervines, things like passion flower, valerian, motherwort, skullcap, all of these tend to increase GABA. Interestingly, some herbal sources consider Vitex to be a nervine. And so that could very well be why one of its effects is working there. So nervine herbs would be another possibility. And then potentially acupuncture, although I haven't seen any studies with prolactinomas specifically there. Generally, if the prolactin levels stay high for more than 6 to 12 months, then we jump over to the dopamine agonist. So if that hasn't worked, then we're going to think about, usually the carbegoline is going to be the treatment of choice. And that's going to be administered about 0.25 milligrams 2 times a week. We increase to 0.5 milligram 2 times a week if necessary. That replaces the older agent, which is bromocriptine. This is an ergot alkaloid. This inhibits prolactin secretion, but high doses are associated with increased pulmonary fibrosis, and then rarely can cause vasospasms, both in the coronary arteries and the brain. So we tend to not use bromocriptine as much as the carbegoline. This is effective in 90% of microadenomas. It restores the ovulation and fertility in women. Generally, we treat for 2 to 3 years, then consider withdrawing. Now, I'm usually doing the level 1, level 2 therapies together. In level 1, I haven't said anything specific, but again, that's where I would go with my general diet, anti-inflammatory diet guidelines or healthy diet guidelines, good exercise, sleep hygiene, and then stress reduction to get the HPA axis down regulated. That would be kind of the treatment, again, 2-3 years on carbegoline. There's some evidence that carbegoline can actually induce cardiac valve damage, and so that's where we might get an echo to evaluate for that. If you don't feel comfortable prescribing this, again, just refer to endocrinology for this. Surgery, again, might be indicated for the larger tumors or ones that are not responsive to the medication, and that would be this transsphenoidal or transfrontal approaches. And then radiation therapy is going to be reserved for patients with no residual tumors post-surgery, so usually after surgery, but have not responded to the dopamine agonists. Response is usually slow from the radiation, can take several years to actually see a full effect. And the gamma knife procedure is one that's being more and more explored for prolactinoma specifically. The major hormone to replace would be estradiol in females, and that would be only after the prolactin levels are stabilized and if estrogen is still low. So you might consider that. But we focus first on trying to normalize the prolactin. So that's the approach to prolactinomas. Now, growth hormone somatotropin adenomas are the second most common functional adenoma of the pituitary after prolactinomas. Again, we might see this in adults, so we're going to manifest primarily with signs and symptoms of acromegaly. And that would be increased growth hormone after those epiphyseal growth plates have closed. So it'll be growth in the hands, and the feet, face, skull, and jaw. Maybe jaw protrusion with spreading of teeth. Growth in the viscera, skin, and soft tissue. Prominent brows, again, the gapped teeth, maybe really large hands and feet. Usually not necessarily excessively tall or large overall, and maybe a coarsening of the facial features. Unfortunately, with all of that extra growth hormone, there might develop secondary diabetes with insulin resistance, hypertension, again, muscle weakness, but even CHF with diastolic dysfunction. The ventricular chambers become enlarged but non-compliant, and then arthritis, obstructive sleep apnea, and osteoporosis as well. So that would be in the adults. In children, again, is the gigantism with increase in body size from increased growth hormone secretion. And that's going to occur before the epiphyseal plates close. The assessment is going to be, again, to measure primarily IGF levels, IGF-1, and then to, of course, do growth curves and to just do a general assessment of body proportion. We're going to maybe confirm this with an oral glucose suppression test. So growth hormone usually after a glucose load should go down, but after a glucose bolus in a growth hormone secreting tumor, it's going to remain elevated. Again, growth hormone is not a reliable test, so we shouldn't get that as a baseline test. And then the MRI might show a pituitary tumor. So again, treatment approach is going to be similar. The medication here is going to be primarily the somatostatin analog, and that would be octreotide, and that's given usually by injection. So this is the case when I would refer to endocrinology to manage this. Transsphenoidal microsurgery followed by radiation therapy has about a 68% efficacy. The dopamine agonists, this would only be in conjunction with the somatostatin analogs. They can work a little bit more effectively. And then there is a growth hormone receptor antagonist that can be given by injection. This is very expensive. I don't have any experience using this, but this is an option for, especially in children, to try to decrease the effects of that excess growth hormone. So less common, but important to know about growth hormone adenomas. Finally, we come to ACTH adenomas, the third most common type of pituitary adenoma. And here we can develop Cushing disease. So Cushing disease is high ACTH from an adenoma causing elevated cortisol. And usually they come from microadenomas. That's when we typically catch the symptoms when they're still in that stage. And they can cause bilateral adrenal hyperplasia, so the adrenals grow in response to all that excess ACTH. The other thing about Cushing disease, which is interesting, this is different than the functional HPA axis disorders I talked about, where we might get a high ACTH cortisol like in the evening versus the morning, etc. Here, the circadian rhythm of ACTH and cortisol is suppressed. So if you instead of seeing the 24-hour rhythm of cortisol, we're just going to see a flat line elevated, both of ACTH and cortisol. There's going to be no appropriate negative feedback of the HPA axis. Usually the age of onset is 20 to 40, and the female to male ratio is 8 to 1. Again, this is a subset of Cushing syndrome, which is hypercortisolism from any cause. So our symptoms will be the same as Cushing syndrome, and that's obesity, especially central obesity. So we have more abdominal obesity, but also fat pads in the back, the so-called buffalo hump, moon facies, and then usually very thin, skinny arms and legs. We get actually muscle atrophy in those areas. Hypertension, diabetes, osteopenia, osteoporosis, excess androgens, and that would be from usually elevated DHEA. Remember, ACTH causes release of both cortisol and DHEA. That DHEA can be converted into androstenedione, which is an androgen, and that can be converted into testosterone. And in females, that's going to lead to excess body, but also facial hair, hirsutism, like a mustache. And then easy bruising, poor wound healing, and purple striae. That's a really specific one. So if you see a patient with these real red, look like purple stretch marks on the abdomen or the thighs, think Cushing's. And that could be Cushing's syndrome in general, but it could be Cushing's disease. Superficial fungal infections, and then menstrual and mental abnormalities. A lot of psychiatric conditions like psychosis even can be triggered by high cortisol. Assessment is going to be, when we'll talk about this in depth with the adrenal section, we're going to do either 2 or 3 tests, either a 24-hour free urine cortisol, an elevated midnight salivary cortisol on 2 different occasions, or a 1 milligram dexamethasone suppression test. So they take dexamethasone, and we should see that that should suppress cortisol secretion following that. If it doesn't, then we suspect there's a pituitary tumor. Importantly, as part of the workup here, is you need to differentiate a pituitary source of ACTH versus a tumor in the lungs or elsewhere that's secreting ACTH. Also, if there's an adrenal tumor secreting cortisol, that would have to be looked at as well. So an adrenal tumor, that's going to be, even with so the dexamethasone suppression test can be actually done at the low level, that's the 1 milligram. You could do a high level as well. I think that's over 5 milligrams, up to 10 milligrams. Usually the high dexamethasone suppression test will suppress the pituitary tumors. There's at least some feedback there. But with an adrenal tumor, there'd be no suppression. So we can use the high-dose dexamethasone suppression to test for that. Again, I'll go over this in the adrenal section, so you don't need to know all these details at this point. Imaging with MRI might be used to look for the adrenal tumor as well. Okay, other changes would be hyperglycemia, glucoseuria, hypokalemia. Usually elevated sodium too is going to be present in Cushing's. The treatment here would be, again, removal of the tumor, pituitary tumor, maybe radiotherapy, and then medications could be used to suppress ACTH, but specifically to inhibit adrenal steroid synthesis. So I went over these before. Ketoconazole, high-dose antifungal, metirapone, that blocks cortisol synthesis, and then mitotane is an adrenollytic. So these are all potential for more serious cases to really decrease the cortisol. All right, so I'm not going to talk about the TSH secreting and the gonadotropin secreting tumors because they're, again, very rare. In the final video here on pituitary pathology, we'll go through the posterior pituitary hormone, specifically ADH, and look at the 2 disorders associated with that.